Hello, everyone. Welcome. Welcome so much to the Pharmacy Technician Symposium for this year, 2023. And first off, congratulations and just a huge excitement, I guess, for what is today International Pharmacy Technician Day. Delighted to be offering this particular symposium on such a special day where we celebrate the contribution that pharmacy technicians are making to the world of pharmacy. I am Susan James, the current chair of the Pharmacy Technician Advisory Committee, and I'm delighted to be able to share with you today some of the information that we have for you over the next couple days, actually, with regards to the current efforts and contributions of pharmacy technicians. Our symposium is Creating a United Pharmacy Workforce, a Strategy for Sustainable Healthcare. We all know just how incredibly important it is right now to be focused on the sustainability of our healthcare system. We've been challenged like no other time, and our workforce definitely is in a very stressed situation, and efforts that we can do to ensure that we have a sustained healthcare workforce are going to be incredibly important to ensure that we have healthcare for all. Before we get into the session today, I would like to first introduce you to Catherine Duggan, who has a few words for everybody of welcome and introduction. Catherine, if you don't know, is the Chief Executive Officer for FIP. I've had the delight of knowing Catherine for many years, and although she has been in the CEO role at FIP for, I believe, 5 years now, Catherine has always been a huge supporter of the pharmacy technician workforce, and more importantly, of the whole team of pharmacy. I think when I think back to my time when I first started working with Catherine at FIP, I was just so delighted with somebody who came with that true vision of one team, everybody contributing at the top of what they have to offer. And I think when we think about sustainable healthcare, it is that concept of all pharmacy professionals, all healthcare professionals working together as one team to support those that need our services. So I am absolutely delighted to be able to introduce Catherine to you, and know that she has a few words of welcome from FIP. Catherine, over to you.
Oh, Susan, what lovely words of welcome from you. And I'm just so grateful to have everyone on this call as part of the FIP family, as part of the FIP team. I'm hugely proud to be CEO of FIP, as you know, and to have our pharmacy technician family here with us today. I believe that this day was initiated primarily in the US in 1991, but in 2016 became an international day, a day really worth a pause and thinking about the contribution pharmacy technicians make to pharmacy, but also to the wider healthcare, as you rightly say, Susan. And in 2020, it's worth us remembering when we went digital or virtual in the middle of the pandemic, we started recognizing this day in a virtual event, and this is our 4th event today. So congratulations to everyone. And in these times of conflict in our world, I think it's really lovely to have an opportunity to pause and reflect and take a moment to recognize the great work of our professions. As you all know, FIP's vision is for a world where everyone has access to safe, effective, affordable medicines. And we know, even before COVID, but especially following the pandemic itself, that vision is not there yet. We have much to do. And our mission is to advance pharmacy worldwide. So we stand shoulder to shoulder across our professions and nations to make sure that we can really advance together and separately. Now, it's worth today, on the anniversary of International Technician Day, to just take a pause and think about some of the global challenges we face. We're halfway to the 2030 target for the Sustainable Development Goals, and the recent United Nations General Assembly really highlighted to us all that there is still much to be done. In many of those goals, we seem to be going a bit backwards. So it's time for us to really think about how we can work together stronger and better. It's also coming up to the 5th anniversary of the Astana Declaration, which happens on the 25th of this month. And at that date in 2018, FIP signed the pharmacy professions up to the delivery of universal health coverage through primary healthcare. It doesn't mean primary care, it's primary healthcare, wherever healthcare is needed. And that means we have a lot to do. We've done a lot, but there's a lot to do. And I think today, as we look back and think what technicians have delivered and their position in the profession, I think it's really important also for us to chart out what's next. There's a huge agenda ahead of us, and COVID really shone a spotlight on what pharmacy in its entirety can do, should do, and was doing. But following the pandemic, we find our workforce weary. We find a lot of challenges in the workforce as they manage the iceberg of healthcare need left after the pandemic, and as they manage their own lives as well. So we have a lot of challenges. Today, Susan has mentioned that the day really focuses on sustainability in the workforce, and this is a major priority for the whole of FIP. Highlighted at our recent Congress in Brisbane, we had a symposium which will result in calls to action being launched on that 5th anniversary of Astana, and pharmacy technicians play a huge place and role and part in delivering that. We will not achieve what our profession needs us to achieve without standing shoulder to shoulder. Alongside that, we need to be supported to practice at the top of our licenses, and therefore I'm really happy to see the competency-based agenda on today's meeting's agenda. It's really important that all of us are supported to do that, and that's what FIP is here to do. We know that our development goals that we launched in 2020 built on the Pharmaceutical Workforce Development Goal. Goal number 10 at that time focused really much on gender equity in the profession. Now the development goal number 10 focuses on equity and equality. And that's really in a response to the inequities we saw in terms of access, socioeconomic status, ethnicity, age, health literacy, etc., that the pandemic really highlighted for us. So I'm really looking forward to seeing the discussions today on equity and equality. But primarily, when we finish today's meeting, a meeting of celebration, of recognition, and of real insight into what you are doing globally as a profession, we'd like a list of your priorities and skills, and we'd like to link you to the work not only within the sections and the boards, not only within the statements and the policies of FIP, but also in the hub where we have the work on the development goals linked. Thanks so much, Susan. Thanks so much to the team on the call today, and thanks so much to everybody listening and participating. I'll hopefully see you all at the end of the event, and I cannot wait to hear more. Thanks a million.
Thanks so much, Catherine. Really do appreciate you taking time out of what I know is an extremely busy schedule. And again, I think that is an evidence of your real support, ongoing support that you have had for the pharmacy technician activities connected with FIP. Just before I hand everything over to Ryan Burke, who will be our core moderator throughout all of the symposium today, I want to just let you know that the Pharmacy Technician Advisory Committee, which is the group that is hosting this particular symposium, has been in place since 2019. Although FIP started actively, outwardly working with the pharmacy technician group and holding an annual symposium previously connected to the Congress every year since 2012. So the work certainly has been ongoing for a long time. And in 2019, we were able to establish an advisory committee, which has many individuals that are on the committee. It is a group of pharmacy technicians and pharmacists who come together really with just a keen interest to support the effort of the pharmacy technician work and to provide guidance and advice within FIP and the variety of activities. Catherine has mentioned a couple. There are so many activities where pharmacy technicians and the contribution that can be made are important to that work. The Pharmacy Technician Advisory Committee connects with that work, sometimes is involved in connecting others who are working more specifically in particular areas to that effort. And I want to let everybody know that we are open to additional individuals joining us. It is just a matter of sending a note and letting us know that you would like to make a commitment to engage with some of this work. And over the next 2 days, today and tomorrow, you are going to hear about some of that work and get a good flavor of how this group is coming together and communicating out what is happening. But most importantly, our work is within FIP, where, as I have said, and Catherine has so much supported, the fact that it is about one pharmacy team, and it is all of us coming together to accomplish what we need to do. With that, I will hand things over to Brian Burke, who is going to kick us off for the session today. I will join you again tomorrow. As Catherine said, I am also very delighted with what is a great program, a variety of sessions that we are going to have over the next couple of days, and we'll come together again tomorrow and reflect on that. Brian, over to you. Thanks.
Thank you so much, Susan and Catherine, for your welcoming words. And Susan, thank you so much for your leadership of the Pharmacy Technician Advisory Committee. A lot of the great work that you mentioned certainly wouldn't be possible without your leadership. So we're very grateful for that as well. Welcome everyone to the first of 4 sessions over the next 2 days. We have a really great lineup of speakers and topics, and I really appreciate all of you taking the time to join us to learn about some of the great work of the advisory committee and some of the other great work going on around the globe as it relates to pharmacy technician practice. And so my name is Ryan Burke. I serve as the Senior Director of Professional Affairs at the Pharmacy Technician Certification Board in the United States. And before we get into today's presentation, I want to share with you just a few announcements. And these announcements will actually apply to all 4 of the sessions that we'll have over the next few days. And so one is that the session is being recorded and live streamed for those of you who are not joining us on Zoom. The recording will be available after the presentation at events.fip.org. You are welcome to ask questions throughout the presentation using the Q&A box. But Peter, the co-moderator, and I will facilitate the Q&A session at the end with the speaker. You're also welcome to provide any feedback that you have to webinars@fip.org. And if you are not already a member of FIP, we encourage you to check out FIP membership by visiting fip.org/membership_registration. So it's my pleasure to introduce to you one of the moderators for today's session, Peter Karegwa. Peter is a registered pharmaceutical technologist by Pharmacy and Poisons Board in Kenya. He holds a diploma in pharmaceutical technology from Mount Kenya University and a bachelor's degree in finance and management science from Strathmore University in Kenya. He is an honorary member of the Kenya Pharmaceutical Association, and he is currently serving as national chairman of the Kenya National Union of Pharmaceutical Technologists. And so, Peter, thank you for being here today. I will turn it over to you to introduce our speakers for this session.
Okay. Thank you very much, Ryan, for that. I'm going straight to introduce our first speaker. She is Samantha. Samantha is a senior leader with a strategic and operational experience in clinical practice, pharmacy education, workforce development, and regulation. She is a healthcare professional committed to challenging systematic inequalities for colleagues and patients. Samantha has a passion for equality, inclusion inclusion which she demonstrates through her day-to-day work and alongside her commitment to pharmacy technicians of color and mentoring others in their profession. Welcome, Samantha. We also have Parampreet Bahia. Parampreet has worked in NHS, England, Workforce Training and Education, which was formerly Health Education in England, for 5 years, and last year joined the Pharmacy Integration Program team covering the Southeast region. Parampreet has led the delivery of portfolio programs, including the Pharmacy Practice and Education Supervisor, Training and Accreditation for London and Southeast region. She continues to lead and oversee the design, use, and implementation of trainee pharmacist e-portfolio across England. She is a regional champion for healthcare projects and Change Association, and is one of the co-founders of Pharmacy Technicians of Color Group. Parampreet is advocates for equality, diversity, inclusion within the pharmacy profession, and a wider healthcare.
Thank you very much for that warm welcome. So as I said, I am Samantha Quaye, and you can see that by my name on the screen. Good morning, afternoon or evening, wherever you may be joining from around the world. I am delighted to be here on Pharmacy Technician Day, delivering this session. If you are on social media, I encourage you to look out for the hashtag RxTechDay for posts about the profession. Before I start, I have noted on the link to this session that my day job is listed. So I just need to clarify that I'm here on behalf of Pharmacy Technicians of Colour, or PTOC, which is a voluntary organisation that I co-founded alongside Parampreet, and not in my capacity as an NHS England employee, although I'm sure there will be references to and from various NHS and health related organisations throughout the presentation. Unfortunately, Parampreet can't join us today due to unforeseen circumstances, so I'm afraid you've got me for the full hour. So this presentation aims to explore the topic of equality, diversity and inclusion through the lens of race in pharmacy practice in the UK. The goal is to raise awareness about racial disparities in healthcare and provide best practices for addressing racial inequities. By understanding systemic racism and promoting diversity and inclusion in pharmacy practice, we can work towards a more equitable healthcare system for all. By the end of this session, you should be able to describe who pharmacy technicians of colour are and what we do, understand how racial inequity affects the pharmacy workforce in the UK, and discuss some examples of racial inequities in health. And throughout this presentation, I will use the terms BAME, which we use as a shortened version for Black, Asian, Minority, Ethnic, to refer to people of colour and marginalised groups in the UK. So please forgive me if the terminology comes out in a way that you're not familiar with. That's something that we have within the UK as our terminology. Next slide, please. Thank you. So, who are pharmacy technicians of colour and what are we all about? So we are a special interest group that advocates for racial equity and inclusion in pharmacy. Our aim is to celebrate achievements, to raise awareness of inequalities, and amplify the voices of our group members. When people feel valued and motivated, it supports delivery of high quality patient care and improved job satisfaction. However, when individuals are excluded and face discrimination or racism, it has a negative impact. PTOC deliver informative and interactive sessions to improve people's understanding of cultural differences and support the adoption of anti-racism initiatives. We are a network that promotes inclusion and highlights how everyone can contribute. Next slide, please. So, to describe pharmacy practice in the UK through the lens of race, I need to take you all the way back to our colonial history. So the images on the screen that you can see now, the one in the centre is probably familiar because we've had a coronation recently, and the crown in the middle is of the late Queen's state crown, and set within that is the Koh-i-Noor diamond, which is subject to much controversy. It's now in the Crown Jewels in the Tower of London, and it came to this country following the conclusion of the Second Anglo-Sikh War, when the diamond was acquired by the British Empire. The image on the left-hand side is of an Egyptian sarcophagus. This is one of several Egyptian antiquities confiscated by the British Army and presented to the British Museum, where it still resides. On the right-hand side, we have the Benin bronzes, which were looted from the West African Kingdom of Benin by British troops in the late half of the 19th century, along with other items of significant financial and cultural value. Our country's wealth has been built on the resources that belong to other countries. And the end of the empire didn't lead to the righting of wrongs from the past. More, what happened was that a line was drawn underneath what went before. So the racism of the empire still lives on in how people from the former colonies are treated to this day. What does all of this have to do with pharmacy, I hear you ask? Well, social and economic factors drive health outcomes. We know that social determinants of health relate to conditions in which people are born, in which they grow up, in which they live, where they work, and their age. And this is often affected by your ethnicity in the UK. So that is that many people from BAME heritage live in areas of high social deprivation. In 2022, an analysis by the Runnymede Trust found that people of BAME heritage are 2.5 times more likely to live in relative poverty. So that is that individuals will have an income below 60% of the median population. And this is the result of systemic racism that stems from our colonial past. Next slide, please. What do I mean by systemic racism? So on the screen, you can see that there are 4 levels of racism depicted here. Systemic racism refers to the ways in which racial bias is embedded within societal structures and institutions, resulting in unequal outcomes for people of colour. This can manifest in areas such as education, housing, employment, and healthcare. And the impact of systemic racism in healthcare can lead to disparities in access to care, quality of care, and health outcomes for people of colour. And this can include higher rates of chronic diseases, lower life expectancy, and increased mortality rates. According to the King's Fund, which is an independent charitable organisation working to improve health and care in England, unpicking the causes of ethnic inequalities in health is difficult. Available evidence suggests that a complex interplay of many factors, including deprivation, environment, health-related behaviours, are the cause. So most ethnic minority groups are disproportionately affected by socio-economic deprivation, which is a key determinant of health status in all communities. And racism and discrimination can also have a negative impact on the physical and mental health of people from minority ethnic groups. The next layer down is institutional racism, and this refers to racial discrimination at an organisation level. It is where systems, processes, and practices result in inequitable treatment of people from minoritized ethnic groups. The other levels on the diagram are of interpersonal, so that is interactions between people on an individual level, where racism may be overt or implicit, but it's person to person. And then lastly, the individual racism. This is internalized racism, where there is a conscious or unconscious recognition of a racial hierarchy, where white people are consistently ranked above people of colour. Next slide, please. Thank you. Systemic racism manifests in healthcare in multiple forms for staff and patients. And the images that you can see on the screen, I'll take you through so that you can understand what some of the impacts are within healthcare in the UK. So studies have shown that people of colour experience worse health outcomes than their white counterparts. For example, the risk of coronary heart disease is up to 50% higher in first-generation South Asians than in white European population in the UK. They're also more likely to be diagnosed with certain types of cancer at later stages, which can make treatment less effective. The picture on the left-hand side, where it says pulse oximetry and racial bias, is of a report that came out from the Race Health Observatory based on pulse oximeters. So pulse oximeters were used more frequently at the height of the pandemic to measure oxygen saturation levels within the blood. And what they found was that the more pigmentation you have in your skin, so the darker your skin, the less accurate it was at reading the oxygen saturation levels. And that was because it had been designed, that the technology had been designed without a wide enough test bed, thus introducing systemic racial bias. So it wasn't an intentional exclusion, it's that the system hadn't thought about the equity for people from different backgrounds that would be included in the healthcare system that would need these technologies. And so the report by the Race Health Observatory talks about how to design that out of the system, and not just for pulse oximeters, but also thinking about when systems are designed going forward. At the top, we have a report called No One's Listening. And this is about sickle cell. It's a report that followed a coroner's report into the unavoidable death of a young man experiencing a sickle cell disease crisis who faced failures in care that led to his death. The report found that there was a lack of awareness about sickle cell disease and very little training for people who were looking after those who had been admitted for sickle cell crisis. Healthcare professionals had incorrect perceptions about opioid-seeking behaviour in people experiencing crisis and a lack of empathy. This has led to people who have sickle cell disease and their family feeling mistrust and reluctance to seek care in hospital when they most need it. So this report has come out to talk about why people are not listening, what can be done about it, and make some recommendations about training and how to make things more equitable for people who live with sickle cell disease and thalassemia. Next at the bottom, we have a statement that came from the Welsh health system from Vaughan Gethin, but generally in COVID, we know that there were disparities. So during COVID, Black men were found to be 3 times more likely to die from COVID than white men. The COVID-19 pandemic had a disproportionate impact on most ethnic minority communities. They experienced higher rates of infection and mortality rates than the white population, and in large part due to differences in location, so their geography of where they lived, occupation, deprivation, living arrangements, and health conditions such as cardiovascular disease and diabetes. Ethnic differences in COVID-19 mortality rates declined over the course of the pandemic, and by 2022 there were no excess deaths in terms of ethnic minority groups compared to white British groups. The top right-hand image is of staff during the pandemic, and many frontline staff in the NHS were BAME heritage, and there was not enough personal protective equipment to protect them during the care that they were giving, which led to illness and death in a disproportionate number of staff from a BAME background. The next image down is about mental health, and mental health studies have suggested that Black and minority ethnic communities are at comparatively higher risk of mental ill health and disproportionately impacted by social detriments associated with mental illness. They're less likely to access mental health support in primary care, so through their GP, and more likely to end up in crisis care. And it's been proven that once in the health system, Black and minority ethnic people are less likely to be referred to talking therapies and more likely to be medicated for mental ill health. Again, once in the mental health system, Black and minority ethnic people experience further inequalities and discrimination. Poor health conditions of BME patients is likely to lead to doctors to focus on the physical conditions, despite the fact that some diseases, such as cardiovascular disease, are complicated by depression and other mental health conditions. And last but not least, the bottom right-hand corner depicts maternal mortality reports for Black women in England. So it was found that Black women were 5 times more likely to die in childbirth than white people. And the likelihood of death in childbirth was higher in all ethnic minority groups compared to white people, but significantly more in in Black people, which led to a report called the Ockenden Report, which is where nursing and midwifery recommendations to address that balance. Next slide, please. So, going back to the history of our country and our health service, the National Health Service, or the NHS, was created 75 years ago this year. And at this time, Caribbean nurses, Pakistani and Indian doctors were all invited to relocate to the UK at the time when the country was rebuilding a post-war Britain, and they paid their way to get here and start a new life. The image on the left-hand side is of HMT Windrush, which is one of the most famous ships of the time because it brought across one of the first and largest groups of people who were relocating from the Caribbean to a new life in the UK. And its arrival on our shores has become symbolic of the Windrush generation. Britain was so in need of support from Commonwealth countries that people were brought over in large numbers with limited documentation. Subsequently, in recent times, this has led to people from these groups and their children being subject to deportation in what has been termed the Windrush scandal, which I will leave you to look into at your leisure at a later date. Suffice to say that 75 years after the NHS was formed, we're a much more diverse workforce, but we're still not inclusive in many ways. Next slide, please. On to present day and diversity data. So to show the diversity of the overall population, here are some statistics. On the left-hand side, we have statistics from the government about the population of England and Wales by ethnicity. And the right-hand side, we have the population of the pharmacy profession provided by the pharmacy regulator in Great Britain, again, split up by the different ethnic groups. I'm not expecting you to read all the detail or memorize the numbers, but I'm displaying these tables to acknowledge the fact that the term BAME encompasses multiple ethnicities and it's not one homogenized group. And also to show that comparing detail is not always that straightforward. So we have different organisations that use different data sets and different terminology. So it's not always possible to compare government data with that of the profession. And these were the most comparable. So to distill this, it is to say that 82% of people in England and Wales are white and 18% belong to Black, Asian, mixed or minority ethnic groups, according to the 2021 census data that we have. And this is directly reflected in the overall pharmacy technician population, where 82.1% of pharmacy technicians identified as white. Next slide, please. So, to break this down, of the 20,768 pharmacy technicians in England as of March 2022, 8,443 pharmacy technicians were employed by NHS trusts. 19.2% of pharmacy technicians in NHS trusts in England were from a Black, Asian or minority ethnic background in March 22, compared to 18% of the general population. So that's just for the managed sector or secondary care, so our healthcare systems. In community pharmacies, so the pharmacies on the high street, an annual survey is conducted in England, and ethnicity data that are collected show that of the 6,544 pharmacy technicians working in retail, the majority of the BAME pharmacy technicians work in London. To break this down, of the pharmacy technicians who identified as Indian, 44% of that whole population work in London, with 10% working in Leicester, which is in the middle of England. For pharmacy technicians identifying as Pakistani, 28% work in Yorkshire, 25% in the Midlands, middle of England, and 22% in London. Of Black British African pharmacy technicians, 65% work in London and 43% in South East London specifically. Of people identifying as Black British Caribbean pharmacy technicians, 44% work in London and 22% in the Midlands. So the profession may be diverse, but this is not consistent across the country. So you'll have predominantly white areas in different areas outside of London. Next slide, please. And this is important because the lack of diversity can lead to discrimination. So on the left-hand side, we have a picture of snow-capped mountains, also termed snowy white peaks. And what it depicts is that the higher up that you go within an organisation, the whiter it gets in terms of the people at the top. So we know that people in foundation roles tend to be from Black minority ethnic backgrounds, and there are less and less people, fewer and fewer people who are of the same ethnicity in more senior roles. And that can be perpetuated through affinity bias and unconscious bias and racism in recruitment. So people are less likely to get promoted, to be recruited into senior roles or represented in decision-making fora. Even when workplaces have diverse team compositions, they're not always inclusive. On the right-hand side, I'll leave you to read some of this shortly. We have examples of what are termed microaggressions, but these don't feel micro to people who are experiencing them. So this is interpersonal racism, which can be direct, it can be indirect, sometimes it can be physical, and it can often be non-physical. But these microaggressions are often dismissed by managers who are not culturally competent or not culturally intelligent. So they do not understand the impact of some of the things that are being said or done in terms of what is termed a microaggression, which is to say that these types of things wear people down and affect confidence, performance, and well-being. So how this was described to me and explained to me was like a bee sting. So if somebody said one of these things to you, so they've not pronounced your name correctly, they've anglicised it, and instead of, say, my colleague Parampreet, who can't be here, she uses the name Pam at work, an anglicised name, because it was easier for other people to say. But that changes her identity, it changes her whole experience at work. And that's fine if you have done that yourself, but if somebody else is giving you an anglicised name, it's a microaggression. But again, it's not a micro action, it's a thing that contributes to you feeling like you are not your authentic self at work. And so, as was described to me, if you had a bee sting, you can dismiss one of it, oh, that was a bit painful, but I can deal with that. If you then get stung again, you're like, oh gosh, that was really not good, but it's starting to hurt now. If you have multiple daily, then it can become unbearable. So that is why microaggressions are not micro to the people experiencing them. Next slide, please. So what I've just described about people not getting promoted into senior roles, experiencing discrimination at work, that's not my opinion. That has come from research that is in the paper that is on the left-hand side, which is the seminal paper written by Roger Klein, which you can go and have a look at. So if you treat people poorly, it has a negative effect. This is true of incivility generally, but specifically when racism is involved. And in Great Britain, we have professional standards set by the pharmacy regulator, which is what is depicted on the right-hand side of the screen. And these standards do not explicitly state that equality, diversity and inclusion are a requirement of our professionals, but the expected behaviours that are listed underpin those principles. And how can we expect that our patients will be treated with empathy if we can't treat one another with empathy? There is now robust evidence that how healthcare staff are treated and the diversity in healthcare leadership, that makes a difference to the quality of care that we are providing. And this was evidenced in Roger Klein's seminal paper shown on the left. This led to the production of something called some national metrics called the Workforce Race Equality Standards, which all NHS trusts in England are now measured against. Next slide, please. So how is racism experienced? So you can see on the right-hand side, this is one of the metrics from the Workforce Race Equality Standards, and this is specific to pharmacy. So we have disaggregated the data so that we can see for pharmacy what that means. So this is just one of the indicators that are measured. And we have known for years that there are inequities. People of colour have told us that there were inequities, yet most organisations did not take any action until the Workforce Race Equality Standards were mandated. So now that we have this data, we're an evidence-based profession. Healthcare is evidence-based, so people always want that data. We've now got the data, so that's a really positive step forward, because this information can be used to develop targeted interventions to address the disparities that we are seeing. So the image on the left is that we need to move that dial so that we're making a difference as we go forward. Next slide, please. What is actually being done to address this inequity now that we know about it then? So the Chief Pharmaceutical Officer's Inclusive Pharmacy Practice Delivery Plan to support the diversity in senior pharmacy professional leadership. So within the UK, we have 4 Chief Pharmaceutical Officers, and within England, the team is taking action to address the issues highlighted in the Pharmacy Workforce Race Equality Standards publication. They have 8 projects which are being undertaken across the areas of data, accountability, leadership and talent management, including inclusive recruitment best practice. And that's aligned with the NHS People Plan and Promise, which is shown on the screen. So pharmacy practice is an essential component of healthcare, and it's crucial that diversity and inclusion are at the forefront of our practice. By embracing diversity and inclusion, we can provide better care for patients of all races and ethnicities. And it's important to recognise the unique challenges faced by minority groups in healthcare and to work towards addressing these challenges. Promoting diversity and inclusion in pharmacy practice can lead to improved patient outcomes and increased patient satisfaction. Creating a diverse and inclusive workplace can also lead to improved job satisfaction and retention among pharmacy technicians and other healthcare professionals. To promote diversity and inclusion in pharmacy practice, it is important to engage in ongoing education and training, creating a welcoming and inclusive environment, and actively recruit and retain a diverse workforce. And this goes wider than race. The NHS People Promise is about flexible working, it's about gender equity, it's about equity for people from LGBTQ+ communities and wider. And we all have intersections where we may have one or more of those characteristics that the group that we belong to shares. Next slide, please. So, the ethos of the NHS is that the pharmacy profession should strive to create a diverse and inclusive workplace that reflects the communities that we serve. This includes recruiting and retaining staff from diverse backgrounds, providing opportunities for professional development and advancement, and fostering a culture of respect and inclusivity. Pharmacy teams should receive training on cultural competency to better understand the needs of diverse patient populations. This includes understanding cultural differences in health beliefs and practices, as well as being aware of your own implicit biases that may affect patient care. To address this in England, there is a whole programme of work that has been commissioned for pharmacy staff to embark on their personal journey towards cultural competence. And part of that is depicted on the right-hand side from the Centre of Pharmacy Postgraduate Education, which is a website that you can go to and have a look at, even if you do not live in England. Thank you. Next slide, please. So on to PTOC and what we're doing to support training. So the murder of George Floyd in the US was a catalyst for the Black Lives Matter movement. And that propelled us into a new era where people can no longer say that they didn't know about global issues such as police brutality towards Black people. This extended into healthcare and affected pharmacy technicians of colour who came to individual co-founders before the group existed to express their hurts, their anger and diminished confidence in management and systems due to lack of visibility and not feeling valued or heard, particularly at a time when we were in the middle of the pandemic and these kind of issues were coming up across the world. So we came together as a group to take action and provide education about specific issues affecting pharmacy technicians of colour. One of our first sessions was to encourage people to self-reflect and start their equality, diversity and inclusion journey. And that's what you can see on the screen. So there was a whole webinar where people could come along and learn more about what that meant for them individually, what it meant as from a professional commitment perspective, and think about actual actions that they would take to change the status quo going forwards. Next slide, please. I'm going to take you through a few of the sessions that we have provided, and this was another one that we did at the height of the pandemic. So we covered COVID-19 vaccinations and reasons for vaccine hesitancy. We acknowledged and addressed some of the reasons why people, particularly from Black communities, were reluctant to take up the vaccines. And reasons cited were things like the Tuskegee study of untreated syphilis, where up until 1972, in the United States Public Health Service and the Centers for Disease Control and Prevention, the CDC, experimented on a group of nearly 400 African-American men with syphilis. The purpose of the study was to observe the effects of the disease when it was left untreated. But by the end of the study, medical advancements meant it was entirely treatable. And the men were not informed of the nature of the experiment, and more than 100 died as a result of it. Excuse me. There was also the illegal and or unethical clinical trials in Africa in the 90s, such as the meningitis testing trial in Nigeria, where subjects died or suffered irreversible damage, such as blindness, deafness, or brain damage. And there were also the HIV and AIDS testing within Zimbabwe, where transmissions from mother to baby were tested under duress in this trial and without informed consent, again in the 90s. I'm pleased to say that there have been huge reforms in terms of clinical trials and governance since then, but unfortunately it takes some of these awful things to happen for change to happen. But mistrust of government's intentions was completely understandable as a contributing factor when an undated immunisation protocol is put in place. So by delivering this session, we acknowledged the fears and provided information from evidence-based sources so that people could make informed decisions. So everybody was invited to this. So it was acknowledging some people's fears and answering some questions, providing information, and also for people who didn't belong to those groups to understand why there might be some mistrust within those communities. So rather than just telling people that you must get this, it's absolutely the right thing to do, it's really trying to understand why someone might be hesitant and then letting them make their own autonomous decision with all the information available. Next slide, please. So I've touched on microaggressions earlier on. So we've got that really great diagram from the Royal Pharmaceutical Society. And then we also did our own session on microaggressions and what that meant for pharmacy technicians specifically. So we know that happy people are 30% more productive. And when people experience microaggressions, it stays with them. It affects how they feel and it affects how they perform. So we explained what microaggressions are, how they manifest, and describe the support available and what individuals could do when they experience microaggressions, because often there is a kind of pushback if you raise the fact that you have experienced that. Next slide, please. We've also done a session on what's in a name. So I briefly talked earlier about anglicising names, and names are particularly important in cultural heritage in some cultures. family members are given the privilege of naming a child, and also it can link to all sorts of things from your cultural heritage. So we explored themes of equality and diversity and inclusion in terms of what a name means to people based on their cultural heritage, and not having to kind of fit in. So there's a quote by Brené Brown, which is, "If I get to be me, I belong. If I have to be like you, I fit in." And that's quite a powerful quote, I think, because we can make changes so that people can be accommodated in a workplace, but actually everybody wants to feel that sense of belonging and like they are there in their own right. So that is quite a big difference. So that is something that we try to get across within this session. Next slide, please. It's not all about educating people on all of these issues. We also have celebrations. So we talk about the anti-racism initiatives, but we also celebrate times of cultural and religious significance, and have held events about Diwali, Raksha Bandhan, South Asian Heritage Month, and the events that you can see on screen to celebrate members of our group who come from different backgrounds, and also the things that are important to them from their cultural heritage. Next slide, please. And allyship is possibly one of the most important things that we also talk about. So I didn't address at the beginning of this that I am a white woman in this space. Hopefully that you can see that equality, diversity and inclusion is everyone's business. We cannot achieve that change in silo, and often the power still lies with the white majority. So we have boards and senior teams that don't have people of colour on them. So it's incumbent on all of us to speak up for others when they are not present. And more importantly, to work towards changing the system so that people from all backgrounds are included, because talent is everywhere, but opportunity is not. We need to champion people from all minoritised groups and make our workplaces more inclusive, because it benefits everyone. Next slide, please. And this, I guess, is the so what. So we are providing all this education, speaking at different events such as this. Is it really making a difference? So I would say if just one person goes away from this presentation today curious to find out more, then it is making a difference. But on a wider scale, we also want to make a difference. So at a country level, in the country that I live and work in, the overall workforce race equality data would suggest that we are making a difference. So that's what you can see on the screen now. Workforce race equality indicators, or RES indicators, show how things have changed in terms of each of these categories over time since the RES were mandated in 2016. And I think you can see from that that the trends are going in the right direction. However, change, if you look at the numbers, change is incremental and it's slow, but it is a positive change within the NHS. Next slide, please. So some take-home messages. Many organisations focus on equality, diversity and inclusion because getting it right can lead to increased productivity and attract new employees. So it has a positive impact on the business aspects of an organisation. But it's the social benefit that really matters. An increase in empathy and awareness of others translates into better connections and well-being. It enriches our lives. It helps people to feel valued and understood. So in conclusion, it's imperative that we address racial inequities in pharmacy practice in order to promote equality, diversity and inclusion. This involves understanding systemic racism, its impact on healthcare, recognising and addressing racial disparities in healthcare, and implementing best practices for promoting diversity and inclusion in pharmacy practice. By taking these steps, we can work towards a more equitable and just healthcare system for all our patients. So hopefully you'll have some takeaway messages from today that will enable you to go back to your workplace and have conversations about equality, diversity and inclusion in its widest sense. And that concludes my presentation. So thank you very much for joining, for taking the time to listen. And I am now here for some questions. So thank you for your time.
Thank you, Sam. That was a wonderful and very insightful presentation. I want to encourage the attendees to submit your questions using the Q&A tool within Zoom, and we will read those and get your questions answered by Sam. Sam, maybe while folks are taking some time to think about their questions, I have a few based on some of the information you've presented. So the earlier slide that you shared about microaggressions really resonated with me. And I'm wondering if you have any practical tips to share with the audience here for how to make ourselves more aware of what some of those microaggressions might be, so that, you know, we can be aware and hopefully not say those things to other people.
I think there are various websites that you can go to, and I think you probably can't cover all of the microaggressions that people might experience, because this is not just from a racial equality perspective or racial discrimination perspective. It's also microaggressions in all sorts of places. I think when we delivered the session, we were conscious of the fact that we wanted people of colour who are experiencing those microaggressions, and this would be anyone who's experiencing a microaggression, to have a safe space to go to kind of just sense check how to address the person who might have said that, because often people say these things without any kind of hostile intention. It comes from a place of ignorance. It still means it's racist, and I've done it myself. I'll openly say that it was, you know, it's not something that you would consciously do, I would hope, to discriminate against someone and make someone feel other. However, we all need to be having more of those conversations with our colleagues and learning more about each other and being curious. So that's the way I think is the best way to kind of counteract microaggressions, is to have those conversations. So when they do happen, point them out, start building up that rapport with your colleagues so that you can be challenged and receive that feedback graciously and start to learn. And also that people have that safe space to say, actually, that's not how you pronounce my name, and it doesn't make me feel very included. Simple things like on my email I have, and on my social media posts, I have phonetically how to pronounce my surname. So my surname is of Ghanaian heritage. I get Quaye, Quayle, all sorts of things. It's pronounced Quaye. So I put that phonetically on my email signature, just a way to help people to understand how to pronounce my name. But one thing that we can do for each other is just say, could you just tell me how to pronounce your name, and have a go, because I know that there can be some long names and it sometimes feels intimidating, but I think people would appreciate the fact that you're making the effort to learn about that rather than just ignoring the fact. So there are lots of different tools, I think, that you can use to aid your learning.
Thank you. Excuse me. I was wondering too, in terms of microaggressions, if you are an observer of a microaggression, how might you handle that situation if it's with a coworker?
That is a great question, and that has happened to me. So I've witnessed that, and it was in a group meeting setting, again, where somebody purposely used a different name for someone. So they knew what the person's name was, and it was a name of African heritage. But rather than call that person out in the meeting, because I didn't know whether the individual felt upset by it, I assumed that they did, but I didn't want that assumption to be incorrect. So I approached the person afterwards and said, how did you feel about what happened there? And they said, oh, well, it's just really awkward to say anything, and I don't want to make it into a bigger deal and make it more difficult. So I said, well, would you like me to say something, or would you prefer that I leave it? Because again, you don't want to exacerbate a problem in terms of creating poor relationships between people when it's not actually anything to do. And she's like, well, I wouldn't mind actually. So that gave me the permission to have that conversation with the individual. It was like, oh, it's just banter. And often things can be passed off as, oh, it's just joking, or then you have to explain, but that didn't make that person feel included, they felt other, and they felt embarrassed to say anything or to call you out on it, because the balance, it's often the balance of power is, there's a differential. So this was a senior manager, and it was saying this to somebody who was more junior to them, so they didn't feel able to call it out. So as an active bystander, not calling it out and exacerbating the situation, but speaking to the individual to make sure that they're comfortable with addressing the issue, and then speaking to that individual manager who to make sure that they are aware. And then if it happens again, and actually it did happen again, I'm not, you know, so it doesn't always work, it's not always perfect, it's not a one size fits all and it will be fixed. It happened again, and I went to the person again and said, you've done that again, that's not really acceptable, this needs to stop. And then you have formal organisational processes where you can take out a grievance, or you can, you know, escalate to a manager. And I think those are the appropriate channels if you need that support.
Thank you. Yeah, and certainly these are very difficult conversations and sensitive conversations oftentimes. And so I think your example is a great one in that it might not just be one conversation that solves the issue. It might take multiple conversations and interventions to get there. So we have received a few questions from the attendees. So one of them, and perhaps this is specific to PTOC, so the question is, would you mind creating a class for students in universities? And so I wonder maybe if you could just speak to PTOC, and do you do events sort of external to the organization? Is there an opportunity for people to invite you all to give a talk like some of the ones you mentioned?
100%, absolutely. So we don't have a website, we're a very small group, but we're growing. But if people are interested in some of those resources, we would be happy to share, because as I said, this is equality, diversity and inclusion is everyone's business. And so we need to all support each other to make this a better world.
Absolutely. Thank you. The next question is, what is the level of acceptability of pharmacy technician qualifications outside of the UK or the European Union, for example, African countries in NHS?
Right, so the route to register is with a UK qualification only at the moment. There are discussions, because this changed post-Brexit, for those of you who are aware of us exiting the EU. So the General Pharmaceutical Council is our regulator. They have a specific web page that tells you exactly what you need to do in terms of being able to register as a pharmacy technician. Many of the education providers, if you've completed pharmacy practice somewhere else, will look at accrediting prior learning. So, but that will be based on an individual basis. So you would need to speak to the individual providers and to the General Pharmaceutical Council about that.
And sort of along those lines, we received another question, you know, for individuals who might be coming or moving to the UK from other countries. Can you talk a little bit about, you know, you've covered a lot about racial equity, and is there anything that those individuals might expect coming from, let's say, an African country to the UK as it relates to racial equity? Any concerns that they may have regarding discrimination? You know, are there any resources that might help people in that process?
So what I probably should say as well is that I'm highlighting some of the disparities, the inequities, and some of the negative things so that we can address them. However, there are lots of brilliant things about the UK, and we are a diverse nation, as you've seen from some of the data. So hopefully that doesn't put you off coming to the UK and think that everywhere you turn, you're going to be experiencing racism. That said, there are various different groups. So depending on where you move to, there will be local groups within the organisations that you work for. There are staff diversity groups, and those are for, so you'll have LGBTQ, you'll have women's networks, you'll have BAME networks, and you have kind of all of these different groups that within organisations that you work for. And then within our professional leadership bodies, we also have individuals now who are responsible for looking after EDI for the wider workforce. So there are lots of places for resource. And if you wanted to have a chat to one of us from Pharmacy Technicians of Colour, please do just drop us a line, and we'd be more than happy to answer those questions and help.
Great, thank you. We do still have a few more minutes, so if individuals have additional questions, we'd be happy to take those. Sam, one other thing that I wanted to ask you about is we talked a lot, or you covered a lot in your presentation, sort of dealing with this as it relates to colleagues. I wonder if there's anything that you would approach differently if this were with a patient, or if it's a pharmacy technician working in a community pharmacy with someone who walks into the pharmacy and they might experience a microaggression or anything along those lines. Is there anything you would do differently than if it were a coworker?
I think the routes that you have are different. And so that has, again, definitely happened in practice. So that is about educating your team. So our community pharmacies, our retail pharmacies are much smaller teams. So depending on whether you belong to a large corporate organization or whether it's an individual owned pharmacy, will depend on the support that's available, but the professional leadership bodies again would support. So in the moment, I think it's about understanding where that's coming from, and often these kind of things come out when there's heightened emotion. So in a community pharmacy, I think everybody on the call will probably have had experience of customers shouting at them for whatever reason, and something personal may come out about you. And that would depend on what the thing is that is personal to that individual. And often, again, is not intended, and it's because of another issue, but they're waiting for their prescription and they start shouting about to you about personal things. Most organisations will have a zero tolerance policy in the UK for that. So those customers would then be told, you're not to come back to this pharmacy. Where possible, depending on what the situation is, you'd have that conversation about, so why did you say that? Or, sometimes it's curiosity. It's not, so like we were talking about the microaggressions, then it's about educating people who are part of the public to kind of understand where they're coming from. It just really depends on the situation, I think.
Absolutely. Yeah, I think you've made a good point. There's not really a one size fits all approach to how these things can be handled. So before I turn it over to Peter to close us out, Sam, is there anything else that you want to share with the attendees?
I would just encourage everybody to look into this, and I appreciate that people are coming from different backgrounds from across the world, but there will be different forms of discrimination due to ethnicity in everyone's country. It just might look a little bit different to the UK. So please go away and be curious, have a look at how some of these tools might help you. And if pharmacy technicians of colour can help in any way, then please do get in touch. And thank you for listening.
Thank you. And certainly thank you for your time in putting this presentation together. Please also pass along our thanks to Parampreet. I'm sorry that we couldn't have her here with us, but we certainly appreciate all that you all are doing with PTalk.
Thank you.
So with that, I will pass it over to Peter to close us out. Peter?
Thank you, Samantha. Thank you, Lion. I would want to thank you. Thank you, everyone, for staying put. It was quite a good experience with a lot of information that is good for us. We are looking forward, and we encourage you to stay put for our next session, please.
Thank you, Peter. So if you'll all give us just a couple of minutes to transition to our next session, we will get started in just a moment. And thank you all again. Just give us one moment. I'm just confirming that all of our speakers are ready to go since we are just a little bit ahead of schedule for today's or for the second session. So if you'll all just bear with us for just a minute, we will get started shortly. Thank you. All right. Well, thank you all again for attending our first session, and thank you again to Samantha for her excellent presentation. I'm really delighted to kick off our second session of the day, which will be focused on the competency framework and glossary project that the Pharmacy Technician Advisory Committee has been working on. Again, my name is Ryan Burke. I work at the Pharmacy Technicians Certification Board here in the United States. And we're very excited to be part of this great event today on International Pharmacy Technician Day. It's my pleasure to introduce my co-moderator for this session, Dana Lyons. Dana is a regulated pharmacy technician in Alberta, Canada, a certified Lean Six Sigma Black Belt, and Prosky Change Management professional. Dana is employed with Alberta Health Services on the provincial operations team as a technical practice manager. Dana's work includes leading large-scale projects focused on standardization in process across a system that has 119 hospital sites. Dana's focus is facilitating and leading successful change in pharmacy practice through multidisciplinary pharmacy teams using lean and change management methods to support this work. Dana has dedicated much of her career to improving compounding processes, practices, and mentoring others to successfully achieve quality processes in their pharmacy environment. Dana, thank you so much for being here today. I will turn it over to you.
Excellent. Thank you, Ryan. I really appreciate that. We're going to start with some announcements for today before we start the session. The first one is the webinar is being live streamed, which is excellent. So you can find it on YouTube. The recording will be available after if you're not able to attend the session right now and you want to attend it later or share with your colleagues. And you can find that at www.events.phip.org. Also, we strongly encourage your questions to be put in the question box, and we'll get to those at the end of the session. And that really brings a really well-rounded perspective to the session. So we look forward to your questions. You're welcome to provide feedback on the webinar, and you can see the link is provided there. And then for those of you that are interested in contributing to FIP, we would love you to join, and you can find your membership options at www.phip.org/membership_registration. Perfect. So let's go through the learning objectives for today. So the first one is we're going to explain the purpose of the competency framework project for pharmacy support personnel. The session is going to describe the methodology of the glossary project, purpose and scope, and describe the plan moving forward with each of these projects. I am delighted to introduce our next two speakers, starting with Terry Lynn Fogarty. Terry Lynn Fogarty has been a registered pharmacist in South Africa for 25 years, where she worked in various sectors, including retail, primary healthcare, wholesale pharmacy. Terry Lynn has been involved with the training and assessment of basic and post-basic pharmacy assistants since 2007. Since 2008, she has been a lecturer at Nelson Mandela University, where she's still employed. Terry Lynn was part of the working group who developed the new qualifications for pharmacy support personnel in South Africa. She's currently an evaluator of these of these courses for the regulatory body. And Terry Lynn is also a moderator for the pre-registration examination for pharmacy support personnel. She completed her PhD in 2021, which looked at whether qualifications for PSP met scope of practice needs in South Africa. Welcome, Terry.
Good afternoon, everyone, and thank you for that welcome. I'm delighted to be at and part of the PharmTech Day again this year. So thank you for the kind words in welcoming me, and welcome to all our attendees. So today, last year I presented on the glossary project, and today I'm going to really just present on a bit of an update on that project. So could I have the next slide, please? I will look at, just start with a brief introduction again. We'll have an overview of the Delphi method, which is the chosen methodology that we have gone with. We will look at the project scope, what is involved in the Delphi rounds. I will then just show you a snippet of what one of our glossary entries looks like, and then have a brief slide just on how the glossary can possibly be used once it has been finalized. Thank you. Next slide, please. So just by way of introduction, we embarked on this project in 2021, and then in 2022, we presented the scope of the project. Through various changes and movement of personnel, and changes within our own personal work environments, and through various discussions, we decided as well that we needed to formalize the methodology of the glossary compared to what we presented last year. And so there have been a few delays, but then we have since finalized the methodology, and that is what I am going to be presenting you today. Next slide, please. So just in terms of background again on the project, and just to remind you all what the project is about, the pharmaceutical workforce comprises all cadres who are engaged with healthcare provision, supply, regulation, and production of medicines and medicinal products. Segmenting the pharmaceutical workforce has traditionally been along regulated pharmacists and then non-regulated pharmacy support personnel. But more recently, countries are introducing regulated education and training and registration of their pharmacy support personnel. We've looked at previous work and publications by FIP Ed, the Workforce Development Hub, and more recently the Pharmacy Technician Advisory Committee, and highlighted through these works variances in the use of terminology and meaning pertaining to workforce development. So this additionally reflects the established initial education and training routes to registration as a pharmacist. What do we mean by that? In some countries, there's a bachelor's degree. Other countries require a master's degree or a PharmD route. And in parallel, the variability in pharmacy support personnel education and training is a similar one. You hear in my introduction that we train basic and post-basic pharmacist assistants. We are still awaiting the publication of our regulations for pharmacy technicians, and so that varies from country to country. So one could question why there are these levels of initial education and training degree descriptors to produce a capable and fully functioning equivalent pharmacist in various regions globally. And so a similar narrative from pharmacists exists and is true for pharmacy support personnel. A lack of shared understanding of terminology presents a barrier to advocacy in terms of advancement and of scope of practice of the pharmaceutical workforce. And when appealing to regulatory bodies for equivalence recognition of qualifications in different countries, it becomes difficult when we're not speaking the same language and using the same terminology. Next slide, please. So development of a lexicon of terminology used globally in education, training, and advancement of the pharmaceutical workforce is a pragmatic approach to narrowing this gap between different regions of the world. And in the spirit of one FIP, I think uniting all pharmaceutical fields to present a united professional workforce. The glossary project really aims to ensure that all stakeholders within the profession and around the globe understand what is meant by the terminology used to define the functions and activities related to education and training and advanced practice. So in developing this glossary of terms for the whole workforce, it is envisaged that a common understanding of pharmaceutical workforce development in different countries would be better understood and encourage collaboration between stakeholders from different parts of the world. So the recent global pandemic has further highlighted the critical healthcare provision and scientific roles that the entire workforce contributes, and has had the effect of elevating and enhancing the impact of the workforce globally. So it's timely to consider the value of describing objectively semantic variances and to produce an objective account that may support consolidation and harmonization of global pharmaceutical workforce terminology. Next slide, please. So the methodology that we have chosen to follow for this project is known as the Delphi method. The Delphi method is a widely used research technique that involves obtaining expert opinions on a specific topic through a structured and iterative process. The method is particularly useful when there is a need to reach consensus amongst experts who may have different perspectives or knowledge on a given issue. The Delphi method has been used in a variety of fields, including healthcare, but also in education and business. The Delphi method has proven to be a valuable tool for gathering and synthesizing expert opinions on a range of topics, and its ability to overcome differences in perspectives and knowledge amongst experts makes it a powerful technique for decision-making in complex and uncertain environments. And so I think you can appreciate the reason why we have chosen the Delphi method. So in the next couple of slides, I'm going to describe to you the 4 boxes that you can see on the screen. I will remind you about the scope of the project, followed by how we have selected the panel members and who the panel members will be, and then the process of the Delphi rounds, and then I will close off in terms of how publication will then take place. Next slide, please. So it's essential to ensure that the scope of the glossary before proceeding with the Delphi rounds has been established. This helps in identifying experts to be involved in the process and the terms that need to be included in the glossary. So the scope of the glossary project for this glossary project is to identify terms used globally in initial education and training of pharmacists and pharmacy support personnel, and additional terms that may be used in the advancement of the pharmaceutical workforce. The project does not intend to define scopes of practice of the pharmaceutical workforce, nor qualification outcomes in terms of what skills or competencies are required in different countries. In addition, there are existing terms in glossaries from the World Health Organization, as well as previous projects completed by the International Pharmaceutical Federation. And there is also a glossary on the UNESCO IBE website. Our intention is not to redefine these terms, but rather to include them in a glossary, in a holistic document that can be referred to, giving credit to these organizations that have already done hard work in terms of the glossaries. Right, next slide, please. So who are the panel of experts? The panel of experts should have knowledge and experience in a field or industry, and the experts have been or should be selected based on their expertise and their ability to contribute to the glossary development process. So in the preliminary round of glossary development, members of the International Pharmaceutical Federation Pharmacy Technician Advisory Committee, as well as the Workforce Development Hub Development Goal number 4 task team, which is the Advanced and Specialist Development Working Group, established the initial terms and definitions that should be included in the glossary. We also consulted the FIP Workforce Development Hub at the time to establish the initial list of terms. For the consensus rounds, however, a group of experts in the pharmaceutical field in education and training, including members of the FIP Workforce Development Hub, the Dean's Forum of FIP, and a team of editors from various journals in pharmacy practice will be approached to participate in the survey. And it's important for us to consult with editors of journals, because if you've heard of something called mesh terms, we are hoping that some of our glossary definitions are included in these journals' mesh terms, which then assists in terms of research collaboration going forward. Next slide, please. So that brings us then to just look at the Delphi rounds. So once the group of experts has been identified, they will be requested to participate in the survey. And the survey will include the list of initial terms and definitions. Once I'm done with the slide, I will just show you a summary of where we are at with the glossary entries, and you will see that there are quite a lot of terms that still need consensus. So the expert group will be asked to rate definitions on a Likert scale and make comments if necessary. In addition, each participant will be requested to identify if there are any synonyms used in their country. So they may agree on the definition, but they may say, we don't use the term in this way, we use it in a different way, and they will be given the opportunity to include their synonym in the survey. This will be done for all terms in the initial list. And then at the end of the survey, the participant will be prompted to add any additional terms that maybe haven't been included or thought of. And provided that those definitions are linked to the scope and purpose of the glossary, they may also be included for the next Delphi round, because this is an iterative process, so we have to do more than one round of consensus. So the round of Delphi will ask the group then to provide those synonyms of terms, and if relevant, additional terms may be included in the glossary. And that's just the first round. Once the working group then has consolidated all of that information and further, looked at which terms don't yet have consensus, those terms where there is no consensus yet, or where there are still questions that have been asked, will undergo another Delphi round with the same group of experts until consensus is reached. Thank you. Next slide, please. So where we are at the moment with our glossary entries, we had 182 initial entries, that is terms that were in our glossary. Once we had elucidated those terms, there were 172 terms that were, once we had grouped similar terms together. 67 of those terms, there were definitions that we found on the WHO documentation, or were included on the UNESCO IBE glossary, or were in previously published FIP documents. That left us with 105 terms which still require consensus. So that's quite a large number. And so it will take a little bit of time for us to get to a point of consensus. Having said that, we already have done another round where we have further elucidated the terms, and we are now sitting at a final number of 95 terms that will be required to undergo Delphi rounds. Right, next slide, please. So on this slide, I'm just showing you an example of one of our glossary entries that will require a round of consensus to be, and will be included in one of the Delphi rounds. So you can see it says the term is scope of practice, and we have extracted two terms from two different resources. And what will happen is we will include both of those terms in a survey to our panel of experts, and they will then rate these terms on a scale of 1 to 5, where 1 is it's not applicable at all, and 5 is yes, it's 100% absolutely applicable. We will then go through a process of statistical analysis and determine which of the terms, for example, reaches or can be accepted as being an accepted term where consensus has been reached. And if the statistician says no, there's no consensus on this term, that term would have to then go through another round of Delphi with an updated definition. Next slide, please. And so in this slide, I thought it would be useful just to include some of the, or some items in which we can talk about how the glossary can be used once it is finally published. And so I think for the first one, there's a couple of questions that have already come through on the Q&A. In terms of standardized curriculum development and student mobility, how can my qualification, how does my qualification compare? And although the glossary itself is not looking at a scope of practice or the level of qualification from one country to another, what we are looking at, of course, is improved communication. So institutions and organizations can use the glossary as a foundation for developing a standardized curriculum or training program. And this ensures that the terminology used in different educational institutions and regions can align, making it easier for students then to transition between programs. And for students pursuing pharmacy education in different countries, the glossary can simplify their educational journey. Excuse me. They can rely on consistent terminology, making it easier to understand and apply concepts when they go and study abroad. The second use is in terms of quality assurance for regulatory bodies and accreditation agencies that may use the glossary as a reference to assess the quality and consistency of pharmacy education and training programs worldwide. And this can help ensure that programs meet international standards. And then as far as global research and collaboration is concerned, the glossary provides a common language for pharmacy educators, researchers, and professionals from different countries to collaborate on projects, research, and other initiatives. It will facilitate effective communication. Researchers and authors can use standardized terminology in the glossary to improve clarity and consistency of their publications. And this will then overall improve the quality of research in this field. Another use is the translation of educational materials and resources. And so when educational materials or resources need to be translated into different languages or adapted for specific regions, the glossary can serve as a reference to ensure accurate and consistent terminology usage. Global conferences and events is another area of use. In conferences, seminars, workshops attended by pharmacy professionals from around the world, a global glossary can facilitate effective communication and minimize misunderstandings due to language differences. And then the final use is that I've included, I'm sure there are many more, is on policy and advocacy. So organizations that are advocating for pharmacy education and training standards at national and international levels can then use the glossary to support their initiatives and ensure alignment with global best practices. And that brings me to the end of my presentation. Thank you so much for listening.
Wonderful. Thank you, Terry. Again, please feel free to put your questions in the Q&A box. We are going to move over to our next speaker on this topic, Kat Hall. Kat is a member of the Pharmacy Technician Advisory Committee, principally supporting the governance work streams. She currently works for NHS England in a role focused on the pharmacy workforce alongside the education and training of pharmacy trainees. She has worked with the Royal Pharmaceutical Society as host of a competency framework for all prescribers and a competency framework for designated prescribing practitioners to promote ways of using the framework to support prescribing competence. She was also on the working group of the recent FIP Global Competency Framework for educators and trainers in pharmacy. She previously worked in academia, leading a team delivering a range of interprofessional workplace-based postgraduate programs. Her current research activities focus on the experience of clinical practitioners working in academia and the effects of COVID-19 on the resilience, well-being, and burnout of clinicians and academics. In addition to her work with FIP, she holds a committee role in the UK with the Association for Prescribers and the West London Research Ethics Committee. Welcome, Kat. We'll turn it over to you.
Thank you very much for that introduction. It's always interesting to see your bio there and hear about some of the things that people pick out about you. So welcome to everyone attending live, and also hello to the many others we know join these sessions from the recording, either due to work commitments or time zone conflicts. I've been a part of these symposiums for a few years now, and the move of this annual event to be online has been really exciting for me. I think it really opens up attendance to many individuals who would not be able to travel to in-person global events for many various reasons. And the opportunity to bring global projects to a truly accessible global audience is the power all of us have collectively to really engage and advocate for the pharmacy workforce. In this session, I've been asked to talk about the competency framework project that the Pharmacy Technicians Advisory Committee are leading. If I could have the next slide, please. I'm aware that last year in the 2022 Pharmacy Technician Symposium, we introduced this project. I've tried to minimise the overlap for those who attended last year, and apologies if there is a little bit of overlap, but I also have tried to provide some broad context for anybody in the audience who is new to this project. So I'll start there. I'll then talk a little bit about the progress we've made during this year, so 2013, and then I'll finish with what our next steps and plans are for 2024. For transparency, I'm here today as part of my voluntary role with FIP, particularly in that focus on the governance part of the Pharmacy Technicians Advisory Committee. I'm not representing a specific external organisation in the UK, so I'll keep what I'm talking about generic and global in context as much as I can. Next slide, please. So I always like to start with a little bit of an introduction to the Pharmacy Technicians Advisory Committee. I think we're very aware on the committee that FIP can need a little bit of demystifying for those who are not familiar with our work. Apologies to those who are familiar with this context. So our committee sits as part of FIP Education, which is also known as FIPED. And FIPED is the part of the organisation that brings together activities related to education and workforce development. And within the work streams across that broad portfolio, the PTAC, so the Pharmacy Technicians Advisory Committee, contribute to projects that align to our individual objectives as are agreed for our work. All of this work, not just the work of FIPED and the PTAC, but all of the work that everybody's doing across FIP is always trying to be focused back on the FIP development goals, alongside thinking about activities that build on each other, and really thinking there about the impact that we can make as a global community in incremental steps rather than trying to do lots of projects in isolation. The competency project is a good example of that. So we're here really building on previous work, and I'll explain a little bit more about that throughout the presentation. Just wanted to acknowledge that this is a large piece of global work. There are 3 of us leading it. It's no small undertaking. Each of us has a slightly different area of expertise so that we can complement each other. And as those of you who know us will know, we bring different elements of the global community together there. Kathy, who is a pharmacy technician from Canada, has been a real driver for this project, and I just wanted to particularly acknowledge the work that she's been doing on this. And we're very sorry she couldn't be here with us today, so although I am presenting it, I take no particular credit for being the driver for this project, and really need to acknowledge the work of Kathy and Terry Lynn as well. Next slide, please. So just a little bit about setting the scene and workforce development within that wider context of FIPED. So they're thinking about education, training, development, and workforce. So in the middle there, we have the 2017 FIP report, which was the global descriptive study of the pharmacy support workforce. And this was really an interesting publication that really opened a global discussion about the activities and approaches different countries were utilising in relation to technicians and the support workforce. And this really demonstrated different models for collaboration between pharmacists and then the other members of the pharmacy team. And if you haven't read it, I would encourage you to look at that and some of the information and key highlights that really gave an insight into what those different countries were doing at the time and what their visions were. It particularly highlighted that with the increasing focus on clinically orientated roles for pharmacists, that there was a need to consider how to create space for these activities. And this therefore leads us to a question about how to develop technicians and the support workforce to facilitate this move. Around the same time, the 2016 publication analysing the global pharmacy workforce capacity showed the variety that there was in regions and countries, particularly noting a correlation with economic indicators. And so starting to link in there a little bit with what Sam was talking about earlier, thinking about where there are possibly also global inequalities with access to medicines expertise. So we are, as the pharmacy workforce, bring that medicines expertise, but it is not consistently available across the globe. We also know from this work that more in-depth analyses of pharmacy technician data are needed. And so that's a really big driver here, that we need more information and more in-depth information about what the workforce is doing and what the workforce looks like. So the 2021 paper there on the side, called Advancing a Global Pharmacy Support Workforce Through a Global Strategic Platform, discusses the origins of the Pharmacy Technicians Advisory Committee and the global imperatives for why such a group was designed. I really would encourage you to look at it if you have not already done so, to get a bit of an understanding of how we're trying to advocate for the whole workforce. So within then all of this context, the Pharmacy Technicians Advisory Committee also operates within wider organisational priorities. We don't exist in isolation to the rest of what FIP is doing. And if we consider that in the context of FIPED, then there has been considerable work to design competency frameworks as tools for the workforce. And the impact of this broader work has been consistently demonstrated, in particular through country-specific validation and pieces of research. This evidence base has really driven discussions about which projects the Pharmacy Technicians Advisory Committee could lead on that would impact on the pharmacy workforce. And really there, we're coming back to that idea of how to create space for the whole workforce to be as effective as it can be to improve patient care, because at the end of the day, everybody is here to improve that experience for patients and their journey within healthcare systems. So there is a paper there on the side, which is about the impact of competency frameworks, thinking about development and validity of them. And I'll touch on some of the broader aspects of that 2021 paper through the presentation, but it is there for anybody that would like to look at references like that. So the next slide, please. So I guess the big question is, what does this all mean? So just to set a little bit more of a scene about specifically the pharmacy support workforce. So pharmacy technicians and the pharmacy support workforce operate alongside pharmacists to achieve a common aim. And together we are the whole pharmacy workforce. And the aim of that is to work in partnership and collaboration. This means just as pharmacists have development needs, either in broad or narrow or foundation or advanced levels, the pharmacy support workforce will also have specific needs for development, education and training. This shows there's a clear need for a competent workforce to facilitate delegation of technical responsibilities to well-trained and capable individuals. At the end of the day, without this, pharmacists will not be able to deliver the increasing number of advanced clinically based roles that health systems require of them. And that's also forward-looking. So what might those future roles look like and that future impact we can have on patients? Just to touch back on the 2017 descriptive report about pharmacy technicians and support workforce, this noted that globally there was significant variation in the education, regulation, recognition, roles, supervision, responsibilities that the support workforce has. And there's also variation in terminology, as you will have seen already, either through previous digital events or digital events like this, really culminating in that piece of work that Terry Lynn was talking about. With this variation in technology, it's really, in terminology, it's really difficult for us to think about how we're identifying when we're talking about the same things. And that applies across workforce, education and training initiatives, and really shows the need to establish consensus definitions. Even the terms pharmacy technician and support workforce mean different things in different countries. We know that consensus facilitates better articulation of global aims, which in turn supports communication with stakeholders, and those might be educators, they might be professionals, they might be leadership bodies, or they might just be individuals in the roles. And so that's why the previous work Terry Lynn was describing is so important as the underpinning work for this competency framework project, and why iteratively developing impact can be really powerful if we do it in the right order. So overall, the global competency framework for the pharmacy support workforce builds on that project to provide shared understanding and recognition of the support workforce globally, and then leading into advancement and supporting advancement of the workforce. The impact on the pharmacy workforce and pharmacy technicians and those in support roles will vary by region, but we know that competency frameworks can help by assisting countries to progress the workforce at a national level, provide opportunities for collaboration, support professional recognition systems, and provide a framework for individuals to use for professional development. So I guess the key question you might be asking yourselves is, how do we come to the decision to use a global competency framework to meet those aims? And hopefully I'll be able to explain a little bit more about that. If I could have the next slide, please. At the end of the day, we know the global healthcare workforce landscape is changing, and that's not just because of COVID, but we have changing population health needs, we have changing health systems, we have technological advances, internationalization, movement of people. It's become even more important that we find ways of developing resilient systems, and resilient systems aren't just about processes and organizations, it's also about how we support resilience in our people and our workforce. So for this, if we're going to think about resilience, we need to focus on adaptable, flexible and capable workforces. And that leads us to development of the workforce as a key enabler to delivering high quality patient care and being prepared for future system needs. So to develop pharmacy professionals, we need to think about the broader aspects of workforce education and training needs. There is no one single best model, and so FIP's work focuses on a need for common approaches. We know from the evidence that there are benefits of competency-based education and training, also known as CBET, and we know that they are cost-effective and that they facilitate flexible implementation in different health systems. And that's really important if we're thinking globally. We need to think about how different systems with different funding and models of support and access to technology can use them to the best advantage. So overall, the idea is to provide general frameworks and practices that can be implemented locally to focus on the required outcomes and stages of progression needed for those individuals or groups of individuals. Next slide, please. So when we're talking about education models, FIP's work is focused on a vision of needs-based implementation, thinking about focusing on the services required to meet those needs, and then the competencies needed to deliver the services. And then that leads you to the education required to deliver the services with the required competencies. That's a really important cycle. And I think we always need to remember that those are somewhat interlinked. And it creates a nice structure, and really FIP's work there is focused on things being locally determined, socially accountable, globally collected, and quality assured when we're thinking about education. And you'll see those 4 terms come up quite a lot in some of the handbooks and publications. However, before overarching capability or competence can be ascertained, we need to reflect on the specific competencies that make up what we're talking about. And I realize terminology can be used differently here. So we're reflecting in this context on competencies as the knowledge, skills, attitudes, and behaviours that an individual develops through education, training, personal and professional development, and then importantly, experience. And you can bring those together to articulate them into a developmental framework. How that framework is used can then be determined by the needs of organisations and individuals, and they can use that in the context of their practice, their scope, their area of work, etc. Using a structured approach like that facilitates identifying opportunities, personal development, learning needs, as well as also reflecting on collecting evidence of development and impact. And that can be through a record of an individual's journey to improve their practice. And previous events have focused on how to create portfolios of development for individuals. If you want a bit more information on that, have the next slide, please. If you're interested in learning more about competency-based education and training, there is a 2022 FIP publication, which I've just screen printed there for you so you know what it looks like. That's a lot more depth in there than we can cover in this session, but I just wanted to pick out some context for you that might be helpful in understanding our approach to the framework. So we're developing a framework that focuses on how we can use competencies, and these competencies describe performance in a given context. For example, that might include taking part in continuing professional development, also known as CPD. This competency leads on to a series of measurable behaviours that an individual can demonstrate. For example, one of them might be that the individual documents their CPD activities. This in turn can inform education and training by leading to the design of programmes where learning outcomes support developing these measurable behaviours. So in this project for the competency framework, we're looking at competencies and behavioural indicators, and then we're looking at the more locally and regionally needs-based approach is then for regions, countries and individuals to consider how to use that generic framework and guidance to reflect on their local and individual needs for that lower level education and training to develop it. So just a little bit of information there about how it all flows together. Next slide, please. Developmental frameworks and competency frameworks are now very commonplace in healthcare, not just in pharmacy, across a whole range of professions, and actually not just healthcare, although that's what we're focusing on when we're thinking about pharmacy. We already have a range of global and country-specific frameworks. There are also role-specific frameworks available in some countries, and these are used in a whole different range of mechanisms. So some of them regulate career entry, some of them benchmark standards, some of them are used to develop relevant expertise. And the diagram I've just put there on the slide is from one of their FIP publications and shows the different ways these frameworks can be designed around areas of the workforce. So broad or narrow, advanced, foundation, specialist. Terms you might come across in your own countries include generalist and specialist there as well. So reflecting back on the 2021 paper from earlier that looked at the impact and validation of frameworks, we are aware that although there is commonality between country examples of frameworks, and that commonality is very important, there isn't an even distribution of frameworks across the countries around the globe. So not only is there an uneven distribution, there's also a particular gap noted for pharmacy technicians and support staff. And lots of researchers acknowledge that there is a need for more development in this area. This then feeds back into the work of the Glossary Project, trying to create global understanding of a vision for the workforce. And so a gap in competency frameworks also creates a lack of consensus for some of those terms. So therefore, a global competency framework to articulate development of pharmacy technician and support workforce that could sit alongside the Glossary Project would really help with commonality and international collaboration. Next slide, please. So last year, we presented an update on the initiation of the Competency Framework Project and issued a call for volunteers. This year, we began to look at the development of key indicators related to roles, responsibilities, and tasks. These will shape the behavioural indicators and competencies that will eventually form the framework. Once these are collated into draft one, we will then develop these through expert review with individuals who have experience in competency development, support workforce, or both. We expect this expert review will take place in 2024 and is a really key part as we recognise the role that volunteers play in that work. This will hopefully, fingers crossed, eventually lead to a publishable version, which we've titled version 0 for now, because we recognise that it will be the subsequent country adoption that will provide that key step of validation and refinement that will create such a powerful document once we get there. This is a well-recognised approach to such a large global project, and this engagement with stakeholders at expert review and then following with the validation. Following conversations with members with expertise and competency development within FIPED, the decision was made to start at a baseline with the FIP Global Competency Framework, which is also known as the GBCF. As a project team, there was a clear driver to start with the same broad domains as the competencies that are described already in existing framework. And the GBCF lists the competencies and related behavioural statements and descriptors that are expected of early career pharmacists, so provide a transition point for us. The GBCF has also been through a recent review process, including consensus groups, validation meetings, and iterative content review to reach version 2. We recognise that there are differences in the different professionals that make up the workforce, but having some structure to start with was really important. So we're not copying the GBCF, we're using it as a structural framework to begin the work from. This also helps us think about the wider pharmacy workforce competency needs and supports a consistent approach to terminology and framework development. Next slide, please. So for the detail of what has happened this year, following the call for volunteers and evidence, we collated a repository of existing frameworks and evidence that supported the pharmacy technicians, pharmacy support workforce, pharmacy support personnel. As a result, working groups were devised of volunteers and pharmacy technician advisory committee members who reviewed the existing competency frameworks and scope of practices from 8 countries, including the Netherlands, USA, South Africa, United Kingdom, Portugal, Canada, Singapore, and Qatar. The aim was to develop the beginnings of a framework that will encompass, probably in the final version, 3 levels of behavioural indicators, broadly drawing on the glossary project work, which at the moment will, for the purposes of this, our badges assistant, technician, and advanced. Once finalised and refined, these will determine the minimum level of competence required for those 3 levels of indicators of the pharmacy support workforce, and hopefully serve as a tool to begin thinking about standardising or improving existing training programmes or users to guide educational programmes. And then really driving forward there that needs-based approach for either regulation, recognition, roles, training programs, education and development I touched on earlier. The next steps for the end of this year and during 2024 are to begin refining the outputs of the working groups to identify indicators versus functional tasks, thinking about how we can create those into a developmental framework. We'll need to look for overlap and repetition, and we need to think about consistency in the way different areas are developed as they've been through different groups. And then hopefully from that, we can develop towards that rough first draft, which we can then begin engaging with expert panels on. Clearly, projects like this take a long time, and we know that from frameworks that have been developed previously within FIP. It's important that we get it right, so that we have a good solid version 0, as I badged it on the previous slide, so to really ensure that that country adoption and validation step is as good as it can be to create that really powerful version 1, as it were. Next slide, please. Just on this slide in alphabetical order are the key individuals who very kindly volunteered their time to support the working group stages of this year's work. And particular thanks from Kathy, but all of the Pharmacy Technicians Advisory Committee for giving up your time. So not only do we want to acknowledge the hard work that these individuals took in supporting the project, we also were really pleased to see such engagement from a broad global community of representation across education, pharmacy technicians, pharmacy support workforce, to really give a broad range of voices to what we were trying to do in the working groups. Next slide, please. So what now? It's a big question. Well, firstly, we come back to competency-based education aims that are needs-based. So continued contribution from volunteers to shape the drafting and development of these more final steps of the competency framework are really important, but so will the steps that come after that in relation to validation through country implementation. And that can take time to plan and implement. So for anybody who is interested in that, we would really encourage you to think, reflecting now about the role a competency framework for pharmacy technicians, pharmacy support workforce could play in your activities, and how you could think about what you could do with that in your locality. Secondly, the work of the Pharmacy Technicians Advisory Committee cannot be a success without input from our committee members. If you are interested in any of our activities, then we have different work streams. I've just included some broad concepts there that we do across events, symposia, evidence and resources, engagement and advocacy. Although we've presented a couple of projects here today, that isn't the only work we do. And so even if you're interested in other things that you might be able to do in relation to events and advocacy, and perhaps you're not as interested in taking part in some of the projects we've been talking about, but would like to be involved, please still reach out. We're always looking for building a community and a network internationally. In terms of signposting, I also wanted to mention the currently published frameworks that link into this work broadly, rather than specific competencies and behavioural indicators that might be useful for you to think about and look at. I mentioned the GBCF already. There's also the Global Advanced Development Framework, GADF, the Global Humanitarian Competency Framework, the GBHCF, and the Global Competency Framework for Educators and Trainers in Pharmacy, the GCFE. And that last one is newer and may be of relevance to quite a lot of people on the call who are working in education and training roles. They're all available on the FIP website, and there's also, for some of them, an existing repository of tools and publications to help with local implementation. If you are interested in other related digital events, there are also recordings of previous events showcasing the role of pharmacy technicians, the support workforce, and development of competency frameworks, including those I've mentioned on this website. So I didn't want to leave without just signposting those so that you're aware they're out there if you want to look at some of our linked work. So finally, thank you very much for listening. I'll hand back now to Dana and Ryan.
Thank you so much for that wonderful presentation, Kat. We're going to open it up now to the Q&A. So please go ahead and pop your questions into the Q&A chat box, and we'll get to them. There is a couple questions that were inserted in between the two sessions, and I'm sure that Kat and Terry Lynn will be able to take a stab at these. And the question is around what you have found so far around related to training for entry-level pharmacy technicians in terms of degrees for pharmacy technicians or other entry-level bachelorette programs.
Perhaps I can just talk from a South African point of view, and maybe Kat can then just feed in from her experience. So in South Africa, we have a formal program for our various levels of pharmacy support personnel. As I mentioned in my discussion, that we do have regulations for pharmacy technicians, but they have not yet been published. So we would have 3 levels of pharmacy support personnel, but for all 3 of them, there is a formal qualification. In the new curriculum, which has been rolled out, the lowest level only trains formally for about 6 months. And then the next level for 12 months, and then the final level, which would be the pharmacy technician, would be for 18 months. So in total, to reach the top level of pharmacy support personnel, it would be a 3-year period, or a minimum of 3 years for them to reach that level. And then, with the increase in the qualification, there's also an increase in the scope of practice and what they are allowed to do in a pharmacy. And they're also trained as generalists, so they can work in a community or hospital environment. And then we also have roles for pharmacy support personnel in wholesale. And in South Africa, a very big role in manufacturing. I know that's not like that in all countries, but for us, we use a lot of pharmacy technicians or pharmacy support personnel in manufacturing. And then, of course, we've got a very big primary healthcare community. And then we're also looking to roll out national health insurance. So there's a very big role for pharmacy support personnel in that. And that's the reason for these different levels, all requiring a different level of scope of practice. But yes, also all formally trained.
Excellent. Thank you for that, Terry. Something that popped into my mind, and I wondered if you guys had any indicators, even just really broad indicators, is do we know globally what the number of pharmacy support workforce personnel looks like. Like, how many folks are we talking about? And how does that really compare in terms of percentages to the number of pharmacists? Like, are we talking this group is going to be 2 or 3 times that size when we look at the pharmacy support workforce, or any indicators at all, early days that you guys might have on this?
I think I'll start off by answering there and see if anyone else wants to chip in. I think that's a very complex question because different countries use different definitions, and so it's very difficult for us to ascertain what I'll describe as sort of baseline data when we're comparing different things. So it's not really possible in the same way as it is for pharmacists to get that information. I think that will be a really powerful part of both of these projects, is that a limitation in a lot of the data collected so far shows that data sets between countries are variable. And that actually providing some consensus and articulating that clearly will help to provide better data that we can use. The Global Observatory, which is part of FIP, is also doing some work around this, gathering data. There are bits and pieces in publications, including the 2016 one I mentioned, but it does recognise that collecting that data is quite difficult because of those differences. So I don't know if anybody else wants to add anything there.
Perhaps I can add also, unfortunately, only from a South African perspective. I think what Kat has said is very true. Because we're not actually comparing, even our glossary project, or the scope of that, and defining it as education and training, we started having definitions coming in that were more practice related, and we really had to scale it down and say, okay, no, we're just focusing on education and training because otherwise it gets too large. But just in terms of defining the number of terms that are used to define pharmacy support personnel globally: pharmacy technician, pharmacy assistant, advanced pharmacy assistant, pharmacy assistant specialist, pharmaconomist. It's just so broad, and with each of those definitions, there's a different scope of practice. And so although we're trying to define it in the glossary, it's actually in practice defined by the scope. So that's going to be a challenge that we will still tackle. But yes, in South Africa, we look at a ratio of, as far as our legislation is concerned, 1 pharmacist to 3 pharmacy technicians from a supervision capacity. But as far as the registration is concerned, at the moment, we probably have more like a 1 pharmacist to 1.5 pharmacy support personnel, if I look at the register as it currently exists. But of course, they're at different levels, so it's not just a direct ratio.
Wonderful. Thank you for that. Yeah, really complex question for sure. Another question has come in, and I don't know if from your guys' lens, how you can support this question, but how can a Nigerian trained pharmacy technician be accepted globally, and how will the work that you guys are doing encourage more global acceptance?
I think that's a really good question, and I think is such a big driver for trying to do this work. And I won't go back over what I already said in the presentation, but I think really that movement of people and adaptation of health systems and populations to that movement is really important, and that has been recognised by the WHO in some of their reports, particularly movement of support workforce across all professions, not just pharmacy. In the UK, so in Great Britain, we have the General Pharmaceutical Council, and so that excludes some of the Irish elements of the UK. And we, the GPHC, regulate pharmacy technicians, and so we have, I suppose, a good number, a good idea of the numbers we have, and they have guidance on international qualifications and whether they would be accepted to work in GB. But I would say, though, that one of the things that the work of the Pharmacy Technicians Advisory Committee has shown is that that's not the same in every country. Each country has different recognition of international qualifications, and not all countries regulate their pharmacy support workforce or pharmacy technicians. So it can be very variable. I think I would pose the question back. It depends a little bit on what country you're looking at. There are lots of information on websites out there. For example, GPHC has information on their website if you're looking at Great Britain. But it comes back to that question of that consensus and movement of people. And so I think that's a topic that we're going to come back to a lot over the coming years. Terry Lynn, I don't know if you wanted to add anything from the South Africa perspective.
No, I think you covered it, Kat, by just saying that it depends on the country. And yeah, there's a process in every country, and hopefully these works will contribute to making the transition a smoother one. Thank you.
Excellent, thank you. We had another question come in, and I think Terry Lynn and Kat, you guys have spoken to it already in terms of it really depends on what country you're seeking employment in. And the question really is around, what is the criteria to work in pharma companies in UK and US for a pharmacist from India? So is there anything different you would add there?
I can't add anything, but perhaps Ryan might have an answer for us.
I think it's what Kat and Terry Lynn have spoken about. It really depends. And I think depending on the role within the pharmaceutical company, certainly makes a difference in terms of what requirements might be there. And in the United States, of course, we have 50 different states and a number of territories. And so the rules vary from state to state. And so it's a very difficult question to answer. I would say it depends on where you're going and what the specific requirements are in that particular state or country if you're outside of the US.
Excellent, thank you. And then the last question that's come in here is, can you explain the difference between pharmacy technician and pharmacist from some of the work you guys are doing?
Do you want me to go ahead? Or
do you want to start?
I can start and then you can end off. So essentially it comes down to scope of practice. I think there are some countries where your pharmacy support personnel, for example, in the pharmacologists can work largely independently. But in many countries, pharmacy support personnel or pharmacy technicians work under supervision of a pharmacist and are really there to assist the pharmacist and are often at the patient face, where the pharmacist is doing a lot more of the cognitive evaluation of the prescriptions. The technician is doing a lot of dealing directly with the patient. Again, I think it varies from country to country, but as far as education and training is concerned, in South Africa, for example, a pharmacist has to train at a higher education institution, whereas a pharmacy technician would train at a skills development provider. So they don't have to have the entry requirements to enter into higher education, for example. And so in South Africa, there's only a small provision of assistants that can work without direct supervision of a pharmacist.
I don't have much to add to that, but I think it really comes down a lot to how countries view their healthcare workforce and that autonomy and independence and scope of practice. And there is huge variation. And there is also huge global variation in relation to pressures on the workforce and workforce gaps. And so where healthcare professionals are having to work within scenarios to provide that medicines expertise. And I think sometimes that creates difficulty in some of that consensus work. I think different countries vary. Countries that regulate pharmacy technicians, pharmacy support personnel, and pharmacists tend to have very clear definitions, often related either to a formal register entry with the related regulation for continued professional development, often associated with sort of a minimum educational standard. That might be degree, or also known as credit-bearing study, but it might not. It might be non-credit-bearing training as well. We know that varies by country, and we, as Ryan said, we know that varies by state as well within countries and what employers want for that scope of practice. So I think it very much depends on your locality, and I think some of this work on definitions and consensus will help bring some greater understanding to that. I think probably if you asked an expert panel for their take on that question, you'd probably get lots of slightly different answers from their own context. And that's why FIP's work focusing on that needs of the system in that region is so important to how you contextualize everything on all the educational tools, because at the end of the day, we can only provide some of that broader guidance and support, and it's really that local context which will allow people to use them effectively, for example, to define the difference in development between pharmacists and pharmacy technicians. So apologies, we probably haven't specifically answered the question, but hopefully we've given you enough information to explain why we can't directly give a clear black and white line.
Thank you so much, Kat. I don't see any more questions that have come in to the Q&A chat box. So I would like to close by saying thank you so much to Terry Lynn and Kat for the informative work on the competency framework and the glossary project. You have a lot of work in front of you. We look forward to seeing how this foundational piece of work that you've engaged in shapes up. And so just wanted to send a thank you to both of you for your work and your presentations today. For all of the attendees today, thank you so much for taking time out of your busy days. And I know this global event means that we're here from different time zones, and people have made a lot of different sacrifices to be here to hear about what are some of the initiatives that are going on. It's been a wonderful learning couple hours, and I look forward to what tomorrow brings. But I wanted to just say thank you to everyone for attending, and also let everyone know that all future digital events can be found at events.fip.org. So if you're interested in more of these types of sessions, you can certainly go there. Excellent. Thank you, everyone. And I wish you a wonderful International Pharmacy Technician Day.